All right. Welcome, everyone. Thank you for joining the webinar today. I'm Tiffany Carter. I'm the Perinatal Clinical Community Integration Manager with VNPC. I have just a few announcements, and then I'll turn it right over to our speaker today. First announcement, VNPC launched our community fund, which is a small grant award of up to $2,500 for the purpose of improving maternal and infant health care in local communities. The applications are open now, and the deadline is April 30th. So you can find more information about that on our website, and you can also access the application there. I'm going to throw a link in the chat as well in just a minute. Also, save the date for the 8th VNPC Annual Summit, October 20th through 21st, and it's in Charlottesville this year. Our next regular monthly webinar will be next Tuesday, April 23rd at noon, and the topic will be Black maternal health data and doula services in Virginia. Other webinar series to look out for are our maternal and infant health data series. The second part of that series will be in May, on May 14th. This series that you're in now, 2SLGBTQIA plus families, the last webinar for this series will be next month on May 16th. But all of them are recorded, and you can find them on our YouTube page if you want to watch the others. And also look out for our upcoming special webinar series on perinatal mental health safety, which will be starting in August. And you can register for all of our events on our website, govnpc.org, under events. I'll also put a direct link to that in the chat as well in just a minute. And now I'll introduce our speaker, Featherstone, who uses the pronouns they, them. Featherstone is a dual certified nurse practitioner of women's health and psychiatry. They are passionate about the mental health of parents and LGBTQ plus folks, reproductive justice, and health education. They founded Eucalyptus Health in 2020 to offer psychiatric and sexual health care via telehealth to teens, parents, and adults in Idaho and Virginia. If you have any questions during the presentation, please put them in the Q&A. We will address those afterwards. And I'll turn it over to you, Featherstone.
Thank you so much, Tiffany. I appreciate the warm introduction. I am really excited to share with you all today because the presentation I'm sharing with you is a composite sort of multiple things that I've presented on in the past, things I'm really passionate about, and things that I think we don't talk about a lot as far as folks working with families. A lot of this has touched me personally as a member of the queer community, and also people that I've known and worked with, as well as like clients of other mental health providers who focus on these groups of folks. I know that I've had issues in the past with sharing my screen. Can everybody see? Okay, great. Thank you, Tony. I have no financial disclosures. A little bit about me. If you haven't been to prior presentations that I've given, I've always worked in human-focused jobs. I started in EMS, I moved on to law enforcement, and then I went to nursing, specifically focusing on women's health. Started out in the midwifery program, was a medical provider, did 4 years in labor and delivery before I transitioned to more of a mental health focused position. And now I'm dual certified in psychiatry and mental health. I have some special training working with trans folks and working with eating disorders. Really the focus of this and what I want you all to come away from this today is that there's a really high there's a higher prevalence of non-traditional family and relationship structures within the queer and the neurodivergent communities. And we're really like, that Venn diagram is very compact. A lot of family-facing professionals don't understand the bidirectional relationship of these family structures with the barriers and the strengths that they have in pregnancy, postpartum, and early parenthood. And we need to understand those in order to help them thrive. So we're going to discuss relevance to practice. We are going to talk about a couple different kinds of family structures. We're going to talk about sort of two conceptual models of knowledge and how we're bringing that sense of unknowing to working with these families. And there's going to be a little bit of a heavier emphasis here on non-monogamous or polyamorous families and their strengths and challenges and barriers in more detail. In a review, if you didn't catch LGBTQ 101, one of the things that I really like to harp on is hold your assumptions. And that's going to come up later in this presentation, is that I'm going to give you, I call them iceberg case studies. So this is what you catch at the beginning. This is what it looks like, a snapshot when you walk into that patient office or that patient visit, or when they walk into your office. And then we're going to go into what the backstory actually is in that situation, just so you can be more aware that there's a lot of unknowing and a lot of easy ways that we can make assumptions that are often very wrong. There always will be nuance that we can't see. And so we're going to use the iceberg model for our case studies, but we're also going to talk about the Johari window, which is a psychological concept, a phenomenon that we don't talk about a lot in the medical field. And so I felt like bringing that over will probably be good for us, just to sort of pique our questioning. So the Johari window, very briefly, breaks things into quadrants as far as knowledge. Here we have an axis of whether it's known by others versus whether it's unknown by others. And if we want to move things from being unknown by others and known by us, but we want everybody to know about it in this open area, we need to tell them. But where we're focusing here is not so much on what we need to tell as what we need to ask. So things that we don't know that others do know. So things about this family, things about the relationships that are impacting this pregnancy, this postpartum experience, or this very young child. And things that are unknown by ourselves, but known by others, they call it the blind spot. And so I really want people to be aware of their blind spots, because there's a lot of nuance. There's a lot of subcultures within the community of queer folks. Queer folks are not a monolith. If you have a family with two moms, it's probably going to be really different from a family with a single dad, or a family that has multiple parents, more than two, that you might have someone who doesn't identify as a man or a woman. You might have a non-binary parent. And so all of those families are going to have very different dynamics. They're going to have very different needs. And so we want to just be aware that I don't expect any of you all to come away from these presentations knowing what all these people need. That's not the right attitude. I want you to come away from this presentation knowing that you don't know very much at all. I want you to be aware that there are some trends and there are some things you need to be aware of, but otherwise I want you to ask the really relevant questions and frame why you ask them and why they're relevant, so that people don't feel like you're needlessly invading their privacy. Real broad overview of some really common family structures. So we can have single parent families, either by choice or by circumstance. Someone could be widowed, someone could be divorced, someone could be geographically separated, sort of lone parenting, but not a single parent technically. So I'm thinking like military families where one partner or both, sort of have to switch off with who's taking care of children because of other obligations. There can be families where one or both of the parents has adopted the child. This is really common in same-sex relationships, where only one parent may be biologically linked to the child. And then we have a lot of like blended families, just like there is in the cisgender heterosexual community, where there's children from prior relationships or marriages, from one or both parents, or one or multiple parents. And so you never really know by looking at a family like who's related to who. I was in a relationship at one point in my life where to the naked eye, it looked like me and my female presenting partner had two sets of twins and an older child. Well, it was just because the two children in the middle looked alike. They both had blonde hair and blue eyes, that people assumed they were twins, but really they were just close in age and happened to look alike. And sometimes making mistakes like that as a provider is lighthearted and doesn't cause any hard feelings or discomfort. But a lot of these families, if they're getting this in a clinical environment, you can be sure that they're facing it more and with less tact out in greater society. And so we don't want to compound on difficulties that these patients are facing out in the world in a space that we really want to feel safe and have them be open. We're going to talk about non-monogamous or polyamorous families where there may be 3 or more adults with varying amounts of engagement and legal ties to children, which may, fluctuate based on parent relationships and navigating that, as well as families where there's multiple generations. So there might be, one parent of a child and a grandparent of the child, as well as other partners of either of those adults who are involved in the caretaking, the feeding, the medication administration of one or more children. And then in any situation, we can have a combination of the above. So when I talk about the iceberg model, you can look at people, but you have no way of knowing who is involved outside of that room or to what degree. I'm going to take a minute here to talk about queer culture, because I feel like there are people who can be culturally queer, so culturally tied to the history, the customs, the art, the food, the traditions of 2SLGBTQ culture without identifying as a member of that community. What we're seeing now, as there's been a lot more acceptance and tolerance and fewer barriers to assisted reproductive technology, that we're having more like the children of lesbian families, the children from 2-dad families, the children of parents who came out as queer when those children were then adults. And so having more and more of an awareness that people who even identify as straight might have components of this queer culture that might affect how they parent or how they build community. And we know that community is such an integral part of the postpartum experience and early parenting, because isolation is so deeply problematic and contributes to a lot of mental health issues. While queer culture could technically be considered a subculture of like the greater, North American, United States culture, there are further subcultures and groups within. So like gay male culture, very different from lesbian culture. And then transgender and gender diverse culture has its own like lexicon, has its own meeting places, has its own like sort of metaphors that are used very commonly and terms. And so I want you, like, if you work with any one of these populations in particular, like just because you've worked with several, lesbian parented families doesn't mean that you really know what to look for in other queer families. There's a lot of resource sharing in the queer community. There is an organization called Collage, which I should add to my resource page at the end. And it's the only national organization that focuses on like children of queer parents. And so there's a lot of, specialty terms within that community that can help people sort of identify. So like kids of trans, KOT, people who identify as a KOT, or a donor child, like someone who had 2 moms or 2 people who, couldn't conceive naturally and needed donor sperm, but they don't have a father figure, or, just identifying that they're donor conceived. There's very unique experiences that families and children of those families experience that a lot of other folks don't. I know that I had mentioned last month that the Fenway Institute was sharing a course the other week about supporting LGBTQ families, and it was a webinar. Did anybody go to that? Okay. I ended up going, and it was really, really eye-opening for me. It was lovely. Quick sidebar. The main speaker talked about how his lived experience was that he had been raised by his two fathers. But what challenges they met were also complicated by the fact that one of his fathers was technically, biologically his uncle. Because his birth parents could not raise him for a variety of reasons, mostly substance use. His uncle adopted him, and then quickly his uncle's partner became very involved, was very supportive, took an equal parenting role. And then later on, this young man's sister, his biological full sister from that original family, was also adopted. And so there's a lot of nuance in that family. And this man talks about how uncomfortable it was to be asked to do a Mother's Day craft. And people were always asking where his mother was. And there was a situation that he talked about where he interacted with the medical community, and there was a lot of difficulty that I've changed a little bit to use for one of the case studies, because I think it's really relevant for a lot of the pediatric providers here, for a lot of the OBGYN providers here, for neonatology, for midwives, for a lot of those folks who deal with like early life babies, and how we handle when things do not present the way that we're used to with one man, one woman who are married, and it's very clear-cut family and legal relationships. I'm going to go through some non-monogamous relationship structure terminology. I don't expect you to memorize all this. I just want you to hear it. And maybe one day you'll come across a family who identifies with one of these terms, and you'll be like, oh, I've heard that before. I might not remember what it means, or I have a vague recollection of what it means, but I don't want you to act really surprised, because the more surprised you respond to someone identifying as something you're not familiar with, the more they're going to be like guarded and sort of like protect themselves. And if you can say, you know, honestly, I haven't worked with a lot of families like this, but I'm aware of it. And I'm really glad you shared with me. You will probably see a lot of patients like visibly relax, visibly like unclench, because that fear of being treated poorly is high from a lot of queer people having trauma in medical environments, trauma and mental health environments, and a lot of fear around being under more scrutiny for being different. And a lot of us can understand that, like, no matter who the parents are, if they're active, good parents, if they're, you know, engaged and attentive, like these kids are going to have great outcomes. There's been plenty of research since like the 80s and 90s that kids of queer families do just as well as kids from straight families. But that sort of societal fear is still there. And increased scrutiny is really common in all kinds of minority groups, not just the queer community. So the original definition of monogamy, and I want you all to look at this with a little bit of a critical eye, is the practice of marrying only once during your life and never separating from that partner. And so what is actually happening in most of modern day America is something called serial monogamy, where we are sexually and romantically involved with only one person at a time. And that is sort of socially sanctioned outside of what sort of, you know, this nebulous dating period without exclusivity. But the sort of understood goal is, you know, getting married, staying together, maybe building a family. Those are things that a lot of the non-monogamous community has the sort of metaphor of the relationship escalator. So sort of the idea of you start at the bottom with dating, but the expectations and the steps that are laid out ahead of you and people sort of have inertia to move towards are, we get engaged, we get married, we get a house with a picket fence, we have 2.5 children, we have a Labrador retriever, and everybody lives happily ever after. My experience as a mental health professional and my experience as a queer and poly person are that A, it sets people up for unrealistic expectations, and B, when people are on autopilot, they often have a moment later on in life where they're like, oh, I wish I had thought more critically about that, or oh, I have regrets, or the other partner might be in that situation. And anytime we have a discrepancy in what we want and what we have, it's a problem. And people are set up for grief. So just being aware that like that can be a way that non-monogamous people have really like looked inward, challenged that societal script that is sort of offered. The non-monogamous community will also talk about compulsory monogamy. So sort of the expectation that everyone should be monogamous and that's the right way to be. And so there can be some like internalized shame about like, I know some people are going to judge me for choosing to live my life differently. And really, a lot of the people that they're worried about judgment from are the sort of positions that everyone in this room is in. The person at the WIC clinic who's helping them feed their family, the OBGYN that is supervising the health of the pregnancy, the mom and the baby, the pediatrician who's taking care of their children, you know, all those people that have an inherently hierarchical power differential because they have a lot more education, they have the societal respect of being in those roles. And so please, please, please just be aware of your power when interacting with people who do choose to disclose to you. What a lot of people conflate with like non-monogamy as a broader umbrella term and polyamory, which is having multiple sexual and romantic relationships, is polygamy. And so polygamy is often associated with certain religious groups and especially in other countries where the most common form of polygamy where there's marriage of multiple people to one person is polygyny, which is where there's one man and multiple women. And that's still practiced in a lot of countries in like Africa and sometimes the Middle East. It just depends on that particular culture and the legal status around that. There are some places in the United States, like in Utah, where there's a much larger Mormon population where it is not legally sanctioned, but still practiced. And it really varies in these families about how power is sort of managed. If that one male partner is sort of the head of the family, what degree of autonomy and decision-making authority do the other partners have around their children, around their own bodies? Just things to be aware of and sort of watch out for because there can be problematic and abusive dynamics. And I know we've seen a lot of that in the media as some of these very insular communities in religious sects can be sort of opened up for public scrutiny. Like I said before, non-monogamy is a much bigger umbrella term for any relationship style that is not sexually or romantically exclusive. You'll hear a lot of people talk in the greater culture about emotional infidelity. And so the acknowledgement that there can be exclusivity that is important in terms of both like romance and feelings and emotional vulnerability, as well as physical vulnerability and sexual intimacy. But I will say that non-monogamy is distinct from infidelity. Non-monogamy is an entirely different beast because people go into it with the expectation that there is open communication or at the very least a mutual understanding of what is going on. Non-monogamy is not infidelity. Infidelity is people, proverbially like cheating. There is not openness, there is not communication, there's higher risks of things like STDs because the non-monogamous community in the research actually has lower rates of STDs than their serial monogamous counterparts because there is such a culture around regular STI testing, use of barriers, use of contraception, which is something that we're going to talk about a little bit more later in terms of how that overlaps with the childbearing years in these communities. Like I mentioned, polyamory is the practice of multiple sexual and romantic relationships, and they can have varying levels of intensity or involvement with other partners. So just know that these are big umbrella terms. How people do things is still highly variable. There can be a lot of, like we talked about, hierarchy of power in a medical provider-patient relationship. There can also be hierarchy of power in something we call like couples privilege, where like, say a married couple starts to become non-monogamous and polyamorous, and they start dating outside their marriage. There's a phenomenon where those people, try very hard to preserve that relationship by having like agreements and sort of rules around what is and isn't allowed. And so that might trickle down into some of how you interact with these families and how other partners may or may not be allowed to be involved with children, involved with a pregnancy, and sort of the legal gray area that can be happening there, which opens people up to potential for loss. Because if you have no legal ties to a child and your relationship with the parent ends, this is not unique to the queer community, but there's a high emotional risk there of losing your contact with that child because you don't have legal status with them, just like step parents don't. It's very, very rare for step parents to get any sort of like visitation rights with a child after the rupture of a relationship, because we don't really value as a culture people who are not biologically tied to a young person or an infant. Okay, the next page, very brief review of a couple other terms. One that has come more into the public eye, especially I would say in like your 20s and 30s people, is relationship anarchy. And so it's specifically a non-hierarchical relationship structure where someone, sometimes relationship anarchy people will say that their main partner is themselves, like their main responsibility is to themselves. And they have total independence to develop other relationships as they see fit, without any other person sort of dictating how that goes. And a lot of these people do not cohabitate with other partners to avoid that sort of hierarchical imbalance or a lot of deep entanglement. On the flip side, we have more and more people who are engaging in something called an open relationship. And this is a really nebulous term that can mean a lot of different things to a lot of different people. But the base idea is that there is a dyad where there's explicit permission to have sexual encounters, usually outside of the primary relationship, but there may or may not include a romantic or emotional component to those other relationships. And so that can be something that will evolve for some people, and other people, it works for them. From anecdotal personal experience, I've seen a lot of people where open relationships are sort of a stepping stone into other forms of more non-hierarchical non-monogamy, like polyamory. A more socially sanctioned and I think more visible form of non-monogamy is swinging. And people who engage in swinging are usually called swingers. They have sex with other people outside of their relationship, generally with the other partner in attendance. So you'll hear them use the term swapping, like they'll sort of have two couples and they'll swap partners. Usually this is within the confines of like specific events or spaces. And so there is generally a lot of discouragement of emotional entanglement with people who engage in swinging, but there are lots of examples where people start with swinging and then develop feelings for these sexual partners. And I'm going to have a case study for that like later on as well, because I think it's a really like fascinating sort of progression that people can go through. I want you all to think about polyamorous folks as a marginalized identity or culture that is often invisible. And so like we talked about, there's a lot of fear of stigma or discrimination in the literature and anecdotally. And whenever we have patients who don't disclose things and they have a stigma and they fear negative treatment, it negatively impacts their care-seeking behaviors, and their health status overall. I can't tell you how many queer people I've talked to who are like, I had this terrible experience with a therapist. I can't fathom trying to go through that again. It feels like it's not worth it. And so thinking about that from a pregnancy perspective, if someone has a subsequent pregnancy and they're dreading the interactions they may have, that very easily could lead to a delay in initiation of prenatal care. And we know that an early initiation of prenatal care is such an important way that we screen for and address chronic issues, and early detection of like genetic anomalies and other like neural tube defects. So this is that critical window. We don't want people to be pushed away from care. There's a lot of social disapproval, like we talked about, and even legal discrimination against members of the queer and polyamorous community. I didn't touch on this before, but I think it's really interesting that the greatest, I'm going to put heavy air quotes here, risk factor or predictor of being non-monogamous is being plurisexual. So think of people who identify as bisexual, being attracted to men and women, or people who are pansexual and identify as being someone who is attracted to people all across the gender spectrum. It's not that people who are members of those identities cannot be monogamous, but there is often a desire for exploration that can be ethically explored while still maintaining loving, deep, committed relationships. And that's a container they can do it in. A lot of therapists in the research identify that non-monogamous clients struggle with certain external realities that add stress to what they're actually coming in for, like for therapy. A lot of folks, unfortunately, will not be open to following the language used by a family for how they include additional parents. There was one study that found that people, like providers, would sort of freeze and refer to third or fourth parents as uncles or aunts, which is really not respectful and sort of, what's the word I want to use? It's sort of patronizing by giving them a less involved role. And so like I talked about in LGBTQ 101 was that we really want to mirror the language that our patients, that our clients, that our families are using for themselves. And we want to use open-ended questions that avoid titles so that people can sort of draw you a picture with their words. And like we talked about before, there's a lot of people sort of dismissing the parents that are not biologically related to a child, whatever their legal status is. And from an administrative perspective, especially early on in an infant's life, a lot of intake forms only provide spaces for two parents. And a lot of them will even say mother or father or like guardian. Guardian is not as popular in like NICU environments. But we really need to make sure that people are getting the support they need. And sometimes they need more than two people supporting them in a space like labor and delivery or a space like the NICU. There were a lot of issues in COVID for non-monogamous families because there was such limitation on visitors in hospital spaces, and there was not flexibility around who those visitors could be. Like you had to pick one person beyond the birthing parent who could come and visit in the NICU. And that's incredibly difficult if we have, multiple other partners, multiple other people who are parents. If we have, people who don't necessarily identify as a parent, but are very involved, like a grandparent, or people who aren't legally tied to the family by a sexual relationship, by a romantic title, by legal things, but are very involved from a family of choice perspective. There's a lot of that in the queer community because a lot of these folks will have strained or estranged relationships with family, with biological family. And so we need to be aware that we need to ask, like, who do you need? Who is going to be involved in your child's care? Who's going to be involved in your birth experience? Are there any other people who might come to your maternity care appointments? You know, or your ultrasounds, because ultrasounds are such a big part of bonding with the infant before it's born. And so talking to people about that, being aware that you don't have rigid expectations about, oh, well, you look like a woman, so there must be one man coming with you to all these appointments. Like, just being really clear that you're just aware that other people do things differently, and it's not going to bother you if they are, makes disclosure so much less of a hurdle, because you're opening the door to that disclosure without a lot of tension, without any animosity. I know that a lot of folks, when I start these presentations, they're like, I've never met any polyamorous families. I don't think this is actually happening where I practice. Why are we learning about this? Why? This isn't happening. This isn't relevant. I've got bad news. There's a lot more people doing this than a lot of people expect. And a whole lot of them are parenting. And so if you think it's not happening, it's just that people aren't telling you. So you need to work on making it more of a safe environment psychologically. As far as non-monogamy in general in the United States, approximately 1 in 5 adults have engaged in a non-monogamous relationship at some point. And that study was from 2010 or 2012. And now we're, 12 to 14 years later, and there's so much more awareness of non-monogamy and how it can be practiced ethically. There's even been changes in legal protections for polyamorous people in some parts of the United States. And so I want you, excuse my cat. I want you to read the statistic and think about it. 1/3 of American adults in this one study described their ideal relationship as something other than complete monogamy. That's a lot of people who may engage in swinging, who may engage in an open relationship, who may be initiating a conversation about that with their spouse, with their partner. And that can be something that people are not generally going to be forthcoming about, that may be an unseen source of tension. So think about a marriage therapist where a couple is coming in and talking about sexual difficulties as they're going through infertility, but there's this whole backstory about negotiations about sex with other partners that they're not talking about in that room because the focus is infertility, and they're sort of like holding their breath because they anticipate a lot of pushback about endorsing something that's non-traditional. So just know that sometimes non-monogamy is a problem-solving technique for couples who are dealing with really common issues like libido discrepancy, or one partner realizes that they're queer and the desire is to maintain the main relationship while still allowing that person to explore their identity. There's not a lot of consistency beyond bisexuality or pansexuality that predicts who engages in this lifestyle. So it's not like I can say there's specifically, this amount of education or this racial group or this religion or this geographical region. There is a wide variety. But I will say that within the non-monogamous community, all those other factors, all those other identities are still at play. And people can experience, the same kinds of oppression that they do out in the monogamous community as they do within that pocket, because there is, all the other baggage that we carry from what we're taught growing up. There's one really lovely book. If you do work with non-monogamous folks regularly in your practice, it says Love is Not Colorblind. It's by a Black man who talks about his experience in the poly community and how racism tends to manifest there, even though a lot of the people who come to non-monogamy outside of swinging have usually done some internal interrogation around like, who am I? What do my relationships mean to me? What does commitment mean to me? What are my values in terms of like autonomy or stability or commitment or excuse me, the word for like adhering to social norms. And so people who have not necessarily challenged those things before might have very different, self-perceptions. And that is inherently a part of the queer experience, is challenging social scripts about who you are and what you do and what your value is and what you should do based on what people expect. There are some traits that contribute to non-monogamous identity. And so cisgender men, younger adults, and queer individuals are more likely to report current or prior polyamorous lifestyle or engagement. But what's really great and what I want to share with you all is this study in 2021 of 500 polyamorous people in Canada. More than 40%, like almost half of them, had children living in their homes full-time or part-time. And so this is a community that is not often surveyed in terms of like, we check for socioeconomic data, we check for racial data, we check for ethnic group as far as if people identify as Hispanic or not, but there's not data collected on whether or not people are engaging in a polyamorous or non-monogamous lifestyle. So we have a lot of different ways that we try to measure it, but it's not always very large sample sizes. And so the larger sample sizes we do have, it shows that it's bigger as far as percentage than a lot of us expected. Like 1/3 of people would like to be engaging in this. 1 out of 5, that's 20%, have engaged in it or are right now. But I will say that this is not necessarily a static identity. And so if it's something that is varying, it might be worth, checking in with patients, when they come in for that well baby check, who's still involved? Like, who's helping take care of baby right now? Who's in your family or supporting you? How is everything going with the relationships in your life? We can have estrangement of partners. We can have estrangement of partners. When we have these big blended families in the polyamorous community, it might not be the person who's pregnant whose relationship changed, but it might still affect them. There is a really lovely Instagram account that I love to refer people to see an example of like a polyamorous parenting family. It is called Polyfamery on Instagram, which I think is really cute and funny just from a language perspective. But it's actually a quad. It's 2 couples who are involved and live together, and they have I think there's multiple children. I know they somewhat recently had a baby, and they talk about how the moms will go and do events together, or the dads will go and do events with the kids together, or 3 of them went to this ultrasound appointment, and just giving you a bird's eye view of like what that might look like in your community. Because being visibly polyamorous inherently challenges society, and can be opening people up both to discrimination, but also sort of a form of advocacy and making it clear that these people are living and loving and raising children and doing a lot of the normal things that everybody else does, even though they're doing it slightly differently. I talked a little bit about this, but I wanted to bring it up because I think it's so fascinating. Prevalence of consensual non-monogamy by age in this study in 2019. So when we look at prior relationship, open relationship engagement, the peak incidence is really from 20 to 39. And so those are mostly the years when people are having babies. And that's a lot of, and even if you have somewhere between 3.5% and 4% of people who are reporting as currently engaged in an open relationship, that's probably more than what a lot of you are familiar with in your practice. I know, like, one example that I like to talk about is WIC, and how WIC can have, like, the parent, and there can also be like a designee who can like come and pick up checks and go through classes because they're involved with the infant or the child. In a polyamorous family, that might not be the other biological parent. It might be a metamor, which is where a person is dating or married with someone and that person has another relationship. So from a language perspective, meta meaning like transcending. So like they have a relationship, it's not their paramour, it's their paramour's paramour. And so knowing that colloquially people will refer, my meta means like this person who's important to me, but I'm not dating them. And that is when we do new things, we need new words. There is a glossary with that sort of as the subtext that I really, really love, that is sort of, living language, updated regularly. I believe it's on Medium. And this is just if people are interested for more information about terminology in the non-monogamous community. I believe the author is North Star 9 on Medium. And I'm sure if you search like polykinky glossary, you'll find it. But there's lots of interesting language there that if you know even just a tiny bit, patients will recognize it and know that you're safe. And that will be a lot of social capital with those patients. There was this one really amazing study called the PolyBabe study out of Canada. And it's one of the very few that talks about the postpartum experience of polyamorous families. And just because people are polyamorous doesn't necessarily mean that they have more than two partners. Relationships in people's dating lives can be in flux, but the potential for having more committed, involved partners in parenting is higher when there's polyamory rather than something like swinging or an open relationship. The factors that really buffered these parents were that they had more resources just by having more working adults. Or more social support, which we know is one of the 4 pillars of postpartum mental health. It's having people to talk to. It's having people to keep birthing parents from being just like alone at home. It's people to come over and hold the baby. It's people to come over and fold laundry. It's people to come over and have dinner. There's just generally a larger network of people who identify as family, even if it's not by birth, it's generally more by bond. Like we talked about before, one of the challenges of these families is if they disclose to people or are openly non-monogamous in society, will they be discriminated against? Will they be treated as promiscuous or, tainted or otherwise deviant for having different sexual behaviors? That stigma is really powerful. We touched on briefly that a lot of people will have to explain their family structure again and again and again. And some people can have a sense of humor about it. And for some people, it's uncomfortable and awkward and occasionally painful because they don't like to have to. Those sort of invasive questions and sometimes the toxic curiosity that can come up with providers where questions are asked that aren't necessarily relevant to patient care. And so if you have a queer family or polyamorous family and you're just like, what is happening here? When you're about to ask something, be like, is this relevant to this pregnancy? Is this relevant to this infant? Is this relevant to this infertility treatment? And if it is, but it's not readily clear to the patient why, be prepared to explain it so that you're like, I'm not just trying to be up in your business, but I'm asking this because XYZ. And so they'll understand that at least you're aware that this is a phenomenon that happens and that you're trying to allow them both the privacy they want to have and you're aware of their comfort, but you're still trying to also give them the standard of care by making sure you have the information you need as a provider. Because all of this boils down to bias, these are sort of self-of-therapist issues that we talk about in the mental health world, sort of about examining your own assumptions about relationships and their value, and what do all these different components value to you versus how do you judge them or evaluate them in the context of other people's relationships. So do you value monogamous relationships more than non-monogamous ones? Do you think that they have less commitment? Commitment is a very subjective term. Do you value cohabitating relationships more? Are you aware of the relationship escalator and sort of how there might be pressure on a co-parenting but non-cohabitating queer couple to like get married and live together to parent that infant? Like, do you have expectations that that is going to have a really positive impact? Or rather, is their current situation going to have a really negative impact on that child? And how are you communicating that verbally and non-verbally? This is our first case study. I know a lot of people generally have to go right around one because they have to go back to clients or back to patients, or it's the end of their lunch break. So I'm going to go through these, and feel free, if you're interested, to come back to the recording of the webinar at the 1 hour mark, because I think these are really eye-opening, and I really enjoyed putting them together. From people that I know in my personal life, people I've interacted with in my clinical practice, as well as the clinical practice of two of my colleagues who work a lot with non-monogamous and non-traditional families. So this first case is a man and a woman present for an ultrasound at an OB/GYN clinic. Both seem excited and happy. As the provider, what titles do you tend to use with people in these situations? Do you default to mom and dad? And so I'm not going to hold us up by waiting for responses, but I know that when I was in midwifery school, I absolutely assumed a lot of the time that one man and one woman meant that it was the two biological parents and that they were having the child together and parenting the child together. In actuality, this situation was a friend of mine. He had children from a prior relationship, did not want any more children because he had a genetic condition that he had passed on to his son. His partner of 4 years and him had talked a lot about it, and he did not want to become a parent again because his living child was 17 and he didn't want to start over in his 40s. His partner was younger, decided she wanted to have a baby by herself. It was perfectly fine. He had no objections to her becoming a parent. A lot of people in non-monogamous situations highly value autonomy and not infringing upon another person's decisions about what they do, especially with their lives and their bodies. So she went out and got donor sperm and is pregnant. And the plan is not for them to parent together because he was not interested in becoming a father again, whether biologically or otherwise. But he loves his partner. He wants to come and support her. He wants to share in her joy. He came to the OB/GYN appointments. He came to the ultrasounds. He was at the birth. But it was more focused on his partner than the infant. And I'm sure that he will be a loved person in that family. But they are not partners who identify as building a family together. And so he is absolutely not dad. And the person, when he walked into that appointment, assumed he was dad. And it was very uncomfortable for them to sort of be like, actually, no, this isn't his baby. This is just her baby, but they're in a relationship. Like, that sort of blows some providers' minds that people could choose to have that sort of relationship. It's sort of unheard of in greater society at large. This is a postpartum experience that one of my colleagues told me about that we used as a case study in another presentation. Mish is a queer non-binary femme person who goes by she, they, and Jay is Mish's partner, who is a heterosexual cisgender man who goes by he, him. They recently welcomed their new baby, River. They chose not to gender their baby. They don't disclose to people what genitals that River has because they're really culturally queer and believe that their child should be able to determine their gender when they're older. They're presenting for a 2-month well baby check, and Misha's really tearful. There's a note in the chart from a prior visit that the parents of the baby are 2 women. So now here we have a non-binary person who is femme presenting. So that's probably who they assumed was one of the parents and a woman. But now there's this man here. How do we address that? How do we ask what his role is? How do we sort of clarify? And so I gave you the language earlier, sort of the scripting of like, who's involved in taking care of River? Who lives with River? Who is, helping Mish breastfeed? Do we have enough support? And those are all questions that are good and open-ended, no matter who we think is involved or whether we think it's a straight cisgender couple. Because there are always people in the background who are not in those appointments, and they can be really relevant. So in this case, Mish and Jay were having a really strained relationship. They had been together, I think, like 5 or 6 years. But Mish's partner, Mish had a female partner who was much more supportive and engaged during the pregnancy. And so that woman, I don't remember her name now, but was coming to appointments, was coming to well baby visits, and they just had a situation where her partner couldn't, or their partner couldn't come to a baby check. So dad came. He was available. Even if he wasn't really as engaged with parenting, they lived in sort of a larger polyamorous co-housing environment. So like everybody was there in the home, but like not everybody in the residence was involved with River. But that's not backstory that a lot of people would assume with a non-binary person and a cis man coming in for a well baby check. And some of it is relevant because Jay was not very involved in like the feeding and care of this infant. It really was Mish and Mish's partner. And so that's relevant from a pediatric standpoint. But if you don't know how to engage people openly and with a lot of comfort, like with how you communicate it, people are not going to talk about it. They're just going to nod and smile and move on and figure it out once they leave your office. This was the case study that was shared during the Fenway talk that I really, really loved and that I wanted to share with you all. An 18-month-old and his father present to the ED for a post-fall head injury. Baby bonking their head is like a tale as old as time in the ER, especially a peds ER. Another man shows up with a different last name to the desk asking to be let back. He's saying he's the father. He's very upset. A lot of people are going to say you don't have the same last name. The man who's in the room is the father. Like there's going to be a pause. There's going to be like some whispering. There's going to be like that person's probably not going to be quickly let back to the room. And in a case where someone's toddler is injured, they can be so scared and so frightened. And any delay that happens because of, perceived discrimination in this situation is going to be deeply traumatic. Like, what if that baby doesn't survive? Like, worst case scenario. Most of the time, 18-month-olds bonk their head and they're perfectly fine. And they just observe for a while. But if that other parent isn't allowed back, or it's a third parent, or if it's a grandparent who raises this baby, that's such a distressing situation. And to feel like there's not sensitivity towards that parent's distress really impacts the sense of like trust with the healthcare institution in general. And that distrust that families deal with as queer parents sort of shapes their expectations from next providers, and they can be guarded. The backstory was just like I told you before. This young man was adopted very young because his birth parents had substance use issues. His uncle adopted him and was his father, but very quickly his uncle's partner took on a parent role. His second father had already legally adopted him, but he was not allowed back in the ED until he went and got a paper copy of the adoption papers. Cisgender heterosexual parents do not have to deal with those sorts of barriers. Parents with different last names if they say that they're a parent and the other person confirms it, there's not more questions. No one's asked to show their divorce decree showing that they have custody of a child or anything to that regard in most medical environments. And so making sure that you're treating people fairly like you would their cisgender heterosexual counterparts is really important. I want to share resources now that we're at time. We talked about how the Polybabe study was like the first of its kind, focusing on the polyamorous postpartum experience. It is a qualitative study. It is very, very interesting. They've done a lot more data crunching from that to talk about statistics related to poly folks and postpartum. Very interesting. I didn't talk as much about people who choose to be single parents by choice, but there are resources for them. Singlemothersbychoice.org is the website for them. I wanted to talk about the Queer Spawn Resource Project because a lot of them, it's often updated. It's related to the Collage Project. It talks about a lot of the collage, like children of lesbians and gays, like terminology that if you're aware of, you might catch it quicker in conversation, and sharing a lexicon can build a lot of trust with families. And it also is for like people who are culturally queer, who may not have a queer identity themselves, just to better understand, because as more and more queer people have fewer barriers to entry to parenting, we're going to have more and more people with queer parents. Or parents who identified as queer later in life. And you just want to be aware of that so you can treat people well and understand where they're coming from. I'm going to stop sharing. Do we have any questions?
I don't see any questions in the Q&A, and just since we're over time, I definitely think it was valuable to allow you to continue, and I wanted to capture those great case studies in the recording. So thank you for those. But I am going to get ready to just close this out. Featherstone, would you mind sharing how folks maybe can get in touch with you if they do have some specific questions?
Absolutely. My practice is Eucalyptus Health. I work with patients, specifically parents and queer people, and also folks with eating disorders in Virginia, Idaho, and soon to be coming to DC. I can be emailed at info@eucalyptushealthcare.com, and I'll put that in the chat.
Great. So if you all have like some specific questions, or if you are in a practice and maybe you just need someone to bounce something off of, I'm sure Featherstone will be more than open to that. So you can reach out to her with her emails in the chat. Thank you for joining us today. Look out for our upcoming webinars and special webinar series. You can find them on govnpc.org under events, and we will see you next time.
Thank you so much, everyone. The next session, just so you know, is about intersectionality. And so the queer identity and how it interacts with race and ethnicity, talking about oppression and how it affects families. I'm really excited about the speaker, Stephanie Enriquez. She is a doula and community health worker and therapist up in New York City. And she's a really, really incredible human. So I'm so, so happy that we can bring her in next month.
Thanks, everybody.
Thank you.